ago, I was rushing through my clinic. I was a new minted doctor, and I felt like I was I care about my patients. I was taking care of patients in the hospital and in the clinic. And I was going to see a patient, and I call her Stella, for her post-discharge visit. And I had done 7 post-discharge visits for Stella in the previous 8 months. So she'd had a really difficult year. But I felt like I knew her well and that we had good rapport. So I sort of charge into the room. I have kind of a big lot of personality sometimes. And she was sitting in a chair, and she looked very, very tiny and very, very sad and sick and frail in a way that I'd actually never seen her look before. She was clutching the sides of the chair. She had her oxygen tubing in. And her husband was next to her. And I looked at her, and I had this list of things that I needed to do. And I put it aside, and I said, Stella, what happened? How was the hospitalization? And she looked at me, and she was mad at me. And she said, I got all dressed up to come in here today, and now I'm going to be in bed for 3 days after, and I never, ever want to go to the hospital again. How did I get there? It feels like the goal is to be somewhere way off, that I thought I was on top of the mountain. I thought I understood how to talk to my patients, how to elicit their goals and preferences, how to do good advanced care planning. I'm boarded in that field. I thought, well, what did I do wrong? But I'd never really had the right conversation with her. And when she looked at me and she said that, we changed the conversation that we had in the room that day. And we talked about different pathways for care. And I asked her, I said, Stella, where do you think you are with your disease? And she said, I know I'm dying. And her husband started to cry. And she was right. And that was a place that we could begin a real conversation. But how do I get others to do that? This is not just a problem that I had. How do we make this easier for lots of people? So I dug in. Okay, I can do this. I have a background in quality improvement and systems change, and I can do it. So I did what we know how to do best. I created a curriculum, didactics. We made an EHR module and a smart form and checklists and all sorts of interventions. And wow, this is a great slide. 270% improvement year over year. This was a recent effort that I did in my new organization, but same idea, right? We're changing the advanced care planning for our patients. But what does this really say? So this is showing you that we were able to exponentially increase the number of healthcare proxies in patients' charts. How many of you have a healthcare proxy? Oh my gosh, I want every hand to go up. This is like the easy thing of advanced care planning. This just says, all right, if I'm really sick, who should make decisions for me? Okay, doesn't say what those decisions should be, just says who should we talk to. So it's kind of the easy thing. And yeah, we did really well on this, but look at this next one. So the green bars are, again, showing you how great we are with the healthcare proxies. The little teeny tiny blue bars, are talking about MOLST forms, which is also known as POLST in some parts of the country. So they're a little bit different. A MOLST or a POLST is a way for me to write down medical orders, okay, for life-sustaining treatment. So for my most seriously ill patients, these are actual decisions that we've made as to how their care should proceed. The MOLST or the POLST is the last step in a long process of conversations with patients. And we were not taking that step. That's the step we need to take. We could get healthcare proxies from 100% of our patients. But if your patient, like a lot of my patients, or you don't know where it is, or did you tell your healthcare proxy that they're your healthcare proxy? Did you have a conversation with them? Does your clinician know? So we really needed to figure out, how do we make those blue and green bars closer together for the right patients? Advanced care planning is a big journey, and it's hard to explain a journey when we're supposed to be improving specific processes. I've had some great conversations here about complexity theory this week, and this is really where it comes in. I was treating this problem as complicated, but a series of steps that needed to be followed. And really, this was a complex problem. And we had a big bridge to cross. So 90% of Americans, this is based on the latest IOM report on end-of-life care, which is a really wonderful zillion hundred-page reading. It's actually very good, but quite long. You can read the summary. So 90% of Americans think it's really important to have these conversations, but only about a third have done it. And how many have actually done it with their clinician? You're all kind of nodding. Yeah, the number is dismal. It's getting better. The conversation is changing. This is coming up more frequently, but it's still a big problem. We still don't know how to get across to the other side, how to ask that next question, and how to figure out how to provide care that's concordant with patients' goals and preferences. Why is this so hard? This is not the first time the IOM or other bodies have focused on this. In my home state of Massachusetts, all right, not only did we have sort of this national conversation starting to change, right? Atul Gawande had written his book. There's all this kind of conversation around end-of-life care. Massachusetts actually passed legislation that requires healthcare entities to inform seriously ill patients of the option for palliative care. That's nice. How do they enforce that? We're supposed to give out a brochure, by the way, which was written by the state. You can imagine how beautifully designed it is. So this is a problem. There's a lot of patient engagement efforts going on, which are wonderful, but patients still feel like they can't step forward and engage with their clinician because their doctors often don't know how to respond when they do. And so we're standing on opposite sides of this bridge, far away in the mountain. How do we cross that? And that was really what I focused on. So why is it hard for doctors? So you may have seen some of these headlines. There was a really wonderful blog post around how doctors die that was written, and then a lot of press picked this idea up that doctors die differently. And if you all knew what doctors knew, you'd die differently too. You know, that we choose less intensive care and we never die in hospitals, and it's all really wonderful. And you know what the problem is? It's not true. So this slide, hard to read, I tweeted it out. So although doctors do die, this is a study that looked at occupation as a physician and your odds of dying in the hospital. So yes, we die slightly less in the hospital, and it is statistically significant, but slightly less. However, the rest of our end of life looks just the same as everybody else's. This next one is just funny, and I put it up here because doctors like to think we're somehow superior to lawyers, but we die the same as lawyers too. So in fact, we're all just alike, which I like. So really the point I'm making here is that we're human too. I loved B.J. Miller yesterday talking about how we are all dying. We have all loved someone who has left us. Some of us have cared for someone while they're dying, which is an incredible gift, but will change your life. And it's why when we sit in front of patients, we have a really hard time. There was a great study, and Lucy Kalanithi she tweeted it the other day. Do you know which doctors are some of the worst at predicting prognosis? It's not oncologists, although they're pretty bad. It's actually primary care doctors. The longer you have a relationship with your patient, the worse you get at predicting their prognosis. And it's because we truly love our patients and want to feel hopeful for them. And so we have to understand that. So we're really trying to change the conversation. For the last few years, I've been really fortunate to work with Ariadne Labs. This is Atul Gawande's group with Susan Block and Rochelle Bernacki at really trying to change the conversation around advanced care planning, particularly for patients with serious illness, understanding that it's a journey. This is not one thing that you have to do in your checklist after discharge or before a procedure. That if my patient ends up in a hospital and we don't know what the plan is, that's a failure. I need to make sure that never, never happens. The best part about this model and why I really like it is that first it starts with you. So you have to have an internal conversation. And then, sort of, are you ready to have this conversation? Do you have the information that you and your patient will need? And then the next thing you do is you ask permission of the patient to have this conversation. I have seen great harm, truly, and I believe it's harm, come to patients when doctors kind of march in and say, would you like me to pound on your chest if your heart were to stop? Like, wow. Nobody actually wants CPR. They want the outcome that they think CPR has. And really, I need to know what's important to you. What can you not imagine living without? What makes your life worth living? Because it's different for all of us. And so you ask the patient permission to start that conversation. And if you don't get it, then you wait and you ask again. You say, do you want to bring somebody back, and we'll make an appointment to have this conversation together. And this is how you open the door. This is how I learned. I sat in my patients' homes. I went to their homes to ask them about what it's like to have this conversation. I've asked them after I've had it, well, how did I do? Did I get that right? I learned that here. And that's really important. And they say, no one's ever asked me, and I'm so glad that you did. So are we changing outcomes that matter? It's hard to measure that because everyone's plan and hopes and goals for how they want to die is different. We do know that patients, once they understand their prognosis and are given accurate information, they tend to choose less invasive care, or less intensive care, excuse me. Not all of them do. It's what's right for you. But this is one way to look. So the red and the blue lines are looking at my group along with sort of average Medicare beneficiaries. This is for older patients, in terms of hospice utilization. We tracked right along with Medicare for a long time. After we started changing these conversations, you'll see the lines start to separate. Is more hospice better? I can't say that for sure. I don't know, but I think so. I think that we're letting patients have a different voice in how the end of their life goes. I hope we are. And we are continuing to try to ask them and to figure out data that matters. And the way that we did it is one way. But I think what's important is to understand that it's not just about those forms, and it's not about the checklist. It's about really teaching clinicians to have the conversation, but also coaching them when it gets difficult. So what happened with Stella? We sat in the office, and I spent some time on this. It wasn't and especially a lot of time, to be honest. I didn't blow my whole clinic schedule, but we talked about options for care. This was another great quote from yesterday: healing and curing, or caring and curing. We talked about there's lots of kinds of care that are not curative. And we elected to enroll her in hospice, and I said, you never have to come back to the office. I was fortunate that I could come see her, and she was actually most happy that I said she never had to come see me in the office again, because it really did take a lot out of her. And she allowed me to come visit her at home. And I remember driving down this big driveway. They lived in, was when I was training in New Hampshire. And she and her husband had owned a large farm, and they'd given the farmhouse to her kids. And she and her husband lived in a trailer on the property. And when I walked in, there was a hospital bed and an easy chair set up. And clearly there had been 2 easy chairs before. But she could be in her bed next to her husband. And her bed was next to a window, and so she could watch him tinker, with cars and tools and such in the yard. And behind her, because it was a trailer, so it was long, behind her was the kitchen, and her husband had taken over the cooking, which was something he'd never done before. And he laughed and said, she can't see that I make a big mess back here. And when we put her on hospice, her family rushed. They thought, she's dying, mom's dying, and so everyone came in. She said the first couple of weeks were really exhausting. I was like, okay, I'm all right. She lived another year, and it was really wonderful for her. I want everyone This is my goal, that everyone gets to have that journey that they choose. Not everybody does, but if we can support as many people as possible to be able to have that journey, to be able to feel like when it's time to make hard decisions in a hospital, that you actually know what decision to make, or we can guide you with what decision to make, what your loved one would have wanted. That is a gift. So what's next for all of you as humans is to have these conversations, to talk about what makes life worth living. We're really trying to engage our patients there's lots of great tools out there, from Engage with Grace, the Conversation Project, and I really encourage you to check them out. If you're a clinician, because it's a team sport, if you're a nurse, if you're a social worker, if you're a doctor, we now use all members of our team. Our medical assistants are involved in this. Ask, how might we do this better? How might we advance this conversation? And how might we include patients in that conversation? I love talking about this, and I hope we can continue this conversation on Twitter and after in the hallway, and talk about what's wonderful about life, and talk about what would happen if that were gone, and give your family a gift. Thank you very much.